Vishal sir, we can start sir now, sir.
Sure, we can start. Please, Dr. Rajiv,
Sir,
please
am
come
I
in.
audible, sir?
Yeah, you are very well audible.
Yes, sir. So screen is visible.
Yeah, it is visible.
Yes. Uh, Good morning, everyone. I'll be presenting a case on obstructive jaundice. Here is a patient, a 63-year-old lady, a homemaker, resident of Sikar, Rajasthan, presenting with the complaints of yellowish discoloration of sclera and urine for 1.5 months, and history of pruritus, complaints of pruritus for last 1 month. Coming to history of present illness, she presented with yellowish discoloration of sclera and urine for last 1.5 months, which was insidious in onset, gradually progressive, without waxing and waning, not associated with pain abdomen, associated with not associated with pale colored stools, not preceded by any prodromal symptoms like fever, malaise, and body pain. And it was associated with pruritus for 1 month, which was gradually progressive, started in upper limbs and has progressed to the rest of the body. And the pruritus was intense. It was affecting her daily activities, and she was having disturbed sleep because of the pruritus. She also gives history of loss of appetite, and the history of weight loss, but it was not quantified. Loss of appetite in the form of reduced intake of food. Earlier, she used to take 2 to 3 rotis with rice per every meal, and now she was taking on. She was feeling adequate, or she was not feeling hungry after just one roti. And loosening of clothes were there. So there was a history of weight loss, but it was not quantified. There was no history of fever, no history of vomiting, no history of abdominal distension, no history of hematemesis or melena, no history of cough, hemoptysis, shortness of breath. There was no history of back pain or bony pain. No history of headache, blackouts, or any seizures. She's a known hypertensive for the last 6 years, and she was on antihypertensive medications. No other known comorbidities, no history of previous past surgeries. Uh, Coming to her personal history, she's a vegetarian by diet. Appetite was reduced, as explained, and she did not have any habits, non-smoker, non-alcoholic. Sleep was disturbed due to pruritus, and bowel habits were normal and regular. Family history, nothing was contributory. There was no history of malignancy and first and second degree relatives. And treatment history, before coming to us, she was evaluated at a primary care center with blood investigations and USG ultrasonography of abdomen at a primary care center, and after which she was referred to us, and there was no intervention was done prior to our admission. Shall I summarize the case, sir?
Yeah, please. Yeah,
Hello, sir.
please summarize the case.
A 63-year-old lady, a known hypertensive, presented with painless progressive jaundice for 1.5 months, associated with intractable pruritus for a month, with history of loss of weight and loss of appetites.
So, right, just based on history, what do you think? What could be the provisional diagnosis or differential diagnosis, or what is the pathology which is going on inside patient body? What do you think?
Uh, yes, based on history, it appears to be obstructive jaundice, and I would like to give my differential diagnosis as periampullary carcinoma, hilar cholangiocarcinoma, carcinoma gallbladder, or carcinoma head of pancreas, sir, considering painless progressive jaundice and her age.
I think you have mentioned almost all causes of malignant obstructive jaundice, right?
Yes, sir.
Okay. So first thing is clear that she is having obstructive jaundice, right?
Yes.
Second thing is that she is having some kind of malignancy responsible for this obstructive jaundice, right? It is not the benign cause,
Yes, sir.
right? So what are the points which suggest that it is a malignant etiology of the jaundice, not the benign one?
Sir, painless progressive jaundice itself is one of the factor towards malignant jaundice, sir, and her age
Mhm.
is also there. And
Mhm.
hello, sir, am I audible?
Ah, you are audible.
Yes. Uh, and duration of the jaundice, sir, 1.5 months, suggests more towards malignant jaundice.
Mhm.
And Then no fever, no prodromal symptoms, which can rule out medical causes.
So it is a short duration painless progressive jaundice, right, in an elderly
Yes,
female associated with intractable pruritus, with some
yes,
loss of appetite and weight loss. This suggests
yes.
that it could be the malignant etiology of the underlying jaundice. Right. But why do you think you have mentioned all causes of obstructive jaundice, from gallbladder cancer to hypercholesterol, peri-emptory, head of cancer? But given this history, what is your priority wise? Which one do
So,
you think would be more likely
yes.
in this patient?
So I have arranged it priority wise only, sir.
Okay.
Periampullary carcinoma and hyalocholangiocarcinoma,
So
since it is
why?
painless.
Okay.
Painless progressive jaundice. In carcinoma, gallbladder, after certain stage, patient will have some amount of pain because of local infiltration. And carcinoma head of pancreas is typically explained as painless progressive jaundice, but most of the time patient do come with pain in carcinoma head of pancreas.
So do you think this painless progressive jaundice, and you have specifically mentioned there is an issue of vaccine of any kind of jaundice, is it periampullary carcinoma? Do you think such kind of presentation is
Uh,
relatively more common in peri-ampullary or maybe head of pancreas or head of cholangiocarcinoma?
Among periampullary carcinoma, uh, among the constellation distal cholangio, distal
Hmm.
CBD cancer can present like that, sir. Otherwise, like you said, it is common in hilar cholangiocarcinoma and carcinoma head of pancreas also, sir. Painless progressive
Right.
jaundice.
So I think it would be better to say that you think first of see a head of pancreas. I think then maybe head of cholangiocarcinoma and periamp, because if you say periamp, it means there are four types of malignancy axis, right?
Yes, sir.
Either you
Yes, sir.
specifically say it is a lower end cholangiocarcinoma because the carcinoma head of pancreas itself comes in the purview of periampulous carcinoma. But it is
Yes,
one
sir.
of,
Within
got my point.
yes,
So
sir.
if you
One of
say
the
it is
components
a
of
CA head of pancreas, then it automatically gets included in the periampullary carcinoma. Because
yes,
ampullary, again, it is not the painless progressive classically. Got my point.
yes,
Okay, right. Go ahead with the examination findings.
yes, sir. Coming to a general physical examination, moderately built and nourished. She was conscious,
Okay, just one more
oriented.
thing. One more
Yes.
thing. You mentioned in the history, no history of hemoptysis. So what is the relevance of this history in the context of the symptoms that patient had?
So I'm just trying to rule out any history which can suggest us metastatic disease in lungs.
So you uh, how commonly such metastasis, lung parenchymal metastasis present with hemoptysis also?
Is uncommon, sir. Usually, patient presents with shortness of breath because of
Can you have
infusion.
hemoptysis without cough?
Hello, sir.
Can you have hemoptysis without cough?
Um, Hemoptysis without less likely, sir, but possible.
How it is possible? What is hemoptysis?
Sorry, sir.
What is hemoptysis?
Hemoptysis is
Vishal sir, your voice is low, sir. That's why he is not able
yes,
to listen.
Is it fine now?
Yeah, yes, sir. It's
yes, sir.
better now.
It's better, sir.
Okay. So what is
Yes.
hemoptysis?
So blood in sputum
Okay.
or blood stained sputum.
So when the sputum will be produced,
Yes, sir. It can be associated with cough. Otherwise, also patient will have patient might have a collection of sputum in the throat, especially when patient gets up early in the morning.
mhm,
Yes, sir.
okay. So in case of lung metastasis or hemoptysis of pulmonary origin,
Yes, sir.
will you have cough or not? The reason
Sir,
I'm asking
if
is
it
that because
involves
you want to rule out lung metastasis, right? So
Yes,
you
sir.
might be having some non-pulmonary causes of hemoptysis as per the description you have mentioned, right? It may be some oral
Yes, sir.
pathology or nasal pathology like that, right?
Okay.
But when you have a lung pathology, lung parenchymal pathology, which is causing hemoptysis, can you have hemoptysis without cough?
Okay, sir.
It is unlikely. So I think if you say just no history of cough, I think that is sufficient enough to suggest that there is no clinical pulmonary problems,
Okay, sir.
right? Otherwise, to rule
Yes.
out metastasis, you have to mention all possible symptoms. For example, you have to say there is no history of seizures to rule out brain
Blackout reading.
metastasis.
Yes.
Got my point. So I think
Yes, sir.
you have to just make not very specific symptoms like hemoptysis or until unless
Yes.
there are underlying some relevant symptoms related to that
Okay.
system. For example, patient is having cough. It is a protective
Yes.
cough. Then you can say that there is no history of hemoptysis, even though patient is having cough. Right.
Okay.
Similarly, you can
Yes.
say that patient is having history of headache, right, or giddiness, but there is no history of seizures because
Yes.
there is some hint regarding abnormality in that system that might be because of underlying pathology, which may be related to the your primary pathology in the abdomen. Got my point?
Yes. Yes.
Okay. So go ahead with the examination.
Yes. Coming to general physical examination, she's moderately built and nourished, conscious, oriented. Her BMI is 26 kg per meter square and ECOG status of 1. Pulse rate is 90 per minute regular, and blood pressure is 138 138 by 78 millimeters of mercury. And she was afebrile at the time of examination, and she was maintaining good saturation. And on head-to-toe examination, icterus was present. Marks were noted over the trunk and both upper limbs and lower limbs. There was no pallor, no lymphadenopathy, generalized or left supraclavicular lymphadenopathy, and there was no pediledema. There were no signs of peripheral signs of chronic liver disease. And coming to abdominal examination, sir, on inspection, abdomen was flat, umbilicus was central and inverted. Scratch marks were present. No visible mass, fullness, scar, or engorged veins or peristalsis was noted. Hernial orifices were normal with no visible cough impulse. Renal angle was normal. External genitalia and spine was normal. Normal, sir. On palpation, abdomen was soft, non-tender. Gallbladder was palpable, 8 centimeter lateral to midline, just below the costal margin. Just globular, smooth in surface and non-tender, sir, with well-defined margins all around, except the upper margin, which was continuous with liver. It was firm in consistency. Moved with respiration, and side-to-side mobility was also present. No other palpable mass, sir. No hepatosplenomegaly. Hernial orifices were again confirmed on palpation, were normal, sir. On percussion, liver dullness started in fifth intercostal space, and liver span was 12 centimeter. Dullness noted all over the liver and the gallbladder, which was continuous with liver dullness. Rest of the abdomen was resonant to percuss. There was no evidence of any free fluid on percussion, sir. On auscultation, normal bowel sounds were heard, sir. And on rectal examination and parietal examination, perineal skin was normal, no sinus, fistula, or hemorrhoids. Sphincter tone was normal, sir. No palpable mass or nodule felt in the pouch. And finger glove stained with normal yellow colored stool, sir. No evidence of alina or no blood stainings. Respiratory examination was normal, sir, with bilateral equal air entry and no added sounds. There was no evidence of effusion. And on CNS and CVS examination, it was found to be normal, sir. So after examination, sir, my summary, shall I summarize, sir?
Sure. Yeah, please.
Yes, sir. 63-year-old lady with a non-hypertensive presented with painless progressive jaundice for months and interactive providers with history of loss of weight and appetite. She is icteric with scratch marks and distended gallbladder on examination, with no other palpable mass or hepatosplenomegaly.
Right. So what are your differential diagnoses? Are they same like you have mentioned
Uh,
after your based on
sir,
your history, or do you want to change the sequence?
sir, since gallbladder is palpable and distended, I would like to rule out possibilities of hilar cholangiocarcinoma or less with complete blocks.
No, so
Other
what
than
is,
that,
so based on these abdominal findings, now what are your differential diagnosis in terms of most likely
um,
probability?
sir,
Number one, two, three, four.
with the examination findings, I would still consider my previous differential diagnosis as on history, sir.
Mm-hmm.
Periampullary carcinoma, C8 of pancreas, and carcinoma gallbladder with carcinoma neck of the gallbladder with CBD involvement can still be a possibility, sir.
The first is perianth, then C head of pancreas, then CAGB, most likely CAGB neck, right?
Yes,
And
yes,
no hilar cholangiocarcinoma. Exactly.
yes, yes.
Okay. Right. So this patient is from Rajasthan, somewhere from Rajasthan, right?
Yes.
So that state is her native place, right?
Sorry,
So
sir.
given, so she belongs to Rajasthan, North India,
Yes, sir. Right.
right? So that demographic location of the patient, does it change the sequence? Suppose this patient belongs to somewhere in Bihar or UP. He is a native of that
Sir.
place. He was
Yes,
born
sir.
and brought up there only. And suppose the same patient is in there in Kerala.
Sir.
So
Sir,
based on this
incidence of
demographic,
yes.
do you think the sequence might change or it will remain unaffected?
Sir, incidence of carcinoma gallbladder in North India, especially in Gangetic belt, is higher, sir.
Mhm.
But in this patient, since on examination gallbladder was distended and there was painless progressive jaundice, I kept
Mhm.
this as sequencer. But otherwise, in rest of the population, it is possible to have
No, because
like
you have mentioned carcinoma gallbladder neck as a third difference, right? That's why I
yes,
asked
sir,
you
one of
about
the
that.
differential.
Because
Yes,
you have not totally ruled out carcinoma gallbladder. Still, you have mentioned as one of the
yes, sir.
differentials, right?
Yes, sir. Gallbladder neck
So
with CBD
gallbladder neck.
involvement can.
So that's why I asked the question. Suppose this patient belongs to some place in Bihar or UP, then do you
Yes, sir.
think
That can be priority.
first, and suppose the same
Yes,
patient belongs to somewhere in the south, maybe Kerala or Tamil Nadu, right? So,
yes,
so that might change, I think, right?
yes,
Otherwise, I
yes.
totally agree that it is a. Achha, what do you think? Suppose this gallbladder is palpable and patient is having obstructive jaundice. So, where do you think? What is the level? Where is the level of obstruction in the biliary system?
So level of obstruction is most likely below the junction of cystic duct with CST, sir. Somewhere distal to in the
Or
somewhere in the distal, sir, distal CBD or head of pancreas or periampullary region or duodenum.
right, and
Sir,
it
hello, sir.
might be at the level of cystic duct and CST junction itself, not necessarily always distal.
Yes.
The same
Okay.
pathology which is blocking the CSD can also block the cystic duct, right? CA head of
Yes, sir.
CA gallbladder neck. It is the example.
Yes, sir.
Got my point.
Yes, sir.
And
Possible, sir. Junction exact at the block
yeah,
at the junction is also one of the cause.
what is the relevance of this anatomy in terms of management? I'm just skipping to the management, but because we have discussed about this thing, the gallbladder which is distended because of obstruction somewhere at the level of CSD where the cystic duct is joining or downstream below the level of cystic duct junction in the CSD.
फिर से
So
बिगड़ गई ये। कल कल इधर उधर गए थे। वाह वाह, कुछ तो आया।
okay, so this
Yes.
anatomy has some relevance in terms of management in such patient.
Sorry, sir, I didn't get the question, sir.
My question is that the cystic duct junction with
Yes,
the
sir.
CBD or CSD, right? Does it have some
Yes,
relevance in terms of some endoscopic management for obstructive jaundice in such patients?
yes, sir. Uh, in
What could be the
some patients where there is cholangitis or requirement of drainage, if it is
Mhm.
more proximal block like hilar block, then PTBD can help, and in lower blocks, ERC stenting is more amenable and more feasible.
No, it's other thing that once you place a stent, you just see the, especially for the palliative point of view, where is the junction of the cystic duct, right, in terms of its drainage area. Because if
Yes,
it is lower down, if you put it in a metallic stent, right, that might block the cystic duct
thank
opening.
you. Okay, cystic.
Got my point,
Yes,
right? So that you have to avoid because otherwise the cystic duct opening will be blocked and then gallbladder drainage will be blocked. It may lead to secondary complication of acute cholestasis or maybe angina.
yes.
Got my point. So you have to take care of that drainage is not hampered during the endoscopic
Yes.
management of jaundice, either palliative or pre-operative, whatever. Okay, go ahead.
Yes.
How will you approach this patient?
Sir, this patient already came to us with sonography of the abdomen and blood investigation. Otherwise, I would still like to proceed with sonography and blood investigations, LFT and CVC. Sir. Sonography will directly tell us the level of the block, sir,
So first time
and
this
can
patient has
also
come to you,
give
first
other
time this
information,
patient
sir.
has come to you, what is the sequence of investigation or all the investigation you would like to get at the same time? And what is the aim?
So ultrasonography in most of the Am
Okay, ultrasonography. So do
I
you have
audible, sir?
ultrasound report?
Yes, ultrasonography, sir. Because in more, it is at times it can be considered as an extended part of the examination nowadays, and it is widely available. I can give the idea about the level of obstruction. In this patient, it was a handwritten ultrasonography without much details. They had just mentioned the impression that approximately 33 and 228
ये
mm
प्राइवेट ले
size
जाएगी,
of
प्राइवेट यहाँ से सीधे
quick
प्राइवेट
lesion
रूम।
was seen ahead of him.
हाँ, राउंड हो जाए बस। इसका थोड़ा सा देख लिया, कलेक्शन लगवा दिया है। इसका बस
Rajiv,
वो ऑक्सीजन
make
पे ना
this
इसका मेंटेन नहीं हो रहा है।
Gaurav Rajput as a mute.
Mm.
Rajiv, I'm not co-host now.
So, wait, no, sir.
Mute this Dr. Gaurav Rajput.
Okay. So there is a lesion along the head of pancreas with a cutoff of CBD and LPD.
Yes, sir. There's an abrupt cutoff of
And
CBD and
LPD is
LPD
over
leading to
distended.
retrograde dilatation with moderate bilobar IHBRD.
Mhm.
Otherwise, good detailed sonography would have given us the level of obstruction, sir, and any features in the
Level of obstruction,
liver,
it is
like
there.
any.
See, level of obstruction, it is there. It is at the level of head of
Sir,
pancreas.
yes, sir. That is there, sir. Otherwise, there is no comment on the liver parenchyma. I would
In terms of, in terms of,
liver parenchyma, if there is any lesion in the liver parenchyma and any
okay, if there is any lesion in
lymph
the
node.
liver, if there is any lesion in the liver parenchyma, what could be the differential?
Sir, the volume is low. Sir, you're not audible
I'm saying
clearly, sir.
suppose there are
Yes,
multiple lesions in the liver as mentioned in
yes,
the
sir.
ultrasound. So what could
Yes.
be the differential?
So depending upon the character of the liver, we would have gone for CT scan, sir, and depending
No,
upon the character of the
see,
liver,
we are
whether it
talking
can be
about the
cholangitic
no,
abscess. Yes.
we are talking about the ultrasound at this stage, right? So based on ultrasound
Also,
only, based on
based on
ultrasound only,
ultrasound,
because you mentioned that there is no comment on the liver lesion. So suppose they have mentioned there are multiple small lesions of 1 by 2 centimeter in bilateral lobes, nothing
so
more
based on
than
the
that.
character, whether it is a metastasis or it can be cholangitic abscess,
Right.
the management would have changed. Sir.
Okay. What else do you want to see on ultrasound?
Features of any chronic liver disease in the background.
Chronic liver disease in the background. Okay. Do you expect chronic liver disease in this patient?
Not in this patient, sir. No, sir.
Mhm.
Not in this patient. Patient did not have any etiological factor
Pre-existing.
for CLD.
Pre-existing. Right. Okay. Anything else? What is more
And
relevant to the current situation? See, all
sir,
those
lymph nodes or ascites.
findings you can get, but what are more relevant things that you want to see?
Yes, sir. Ascites if it was present, or lymph nodes if present.
Right.
And
Okay. So what is the sign you can make out based on this ultrasound? Is there any specific sign that you can see based?
sorry, sir.
Any specific sign you can make out based on ultrasound findings?
Um, Dilatation of both MPD and CBD is a double duct
Uh-huh.
sign.
Right. So what does it suggest?
Suggests any lesion in the head of the pancreas or in the periampullary region.
Most likely it is a malignant one.
Yes, a malignant lesion.
Okay. What next? What
Uh,
other things you
so,
want to get besides
sir,
ultrasound? Do you have ultrasound?
so
Right.
blood investigations, LFT, sir, which was confirmatory of obstructive kind of jaundice, sir, with the total bilirubin of 6.5 and direct bilirubin of 5.3 and raised alkaline phosphatase, sir. Total blood count, total leukocyte count was 6.5, sir, and patient clinically also did not have any signs of systemic inflammation. So cholangitis was never there. And other than that, the blood parameters were normal, sir. And
What
CA99,
next in terms of
sir,
it is marginally increased, na? CA 19.9.
yes, sir, 42, marginally increased.
So what next?
Sir, we would go for a triple phase CT or CT pancreatic
So
protocol, sir.
what will you make out based on these investigations? You have got on 19th and then 22nd. So you have CVC, you have LFT, you have serology and tumor markers. So what is the overall interpretation of these blood investigations?
Sir, all these blood reports are still suggestive of obstructive jaundice, sir. Most likely, since it is a progressing, most likely malignant obstructive jaundice.
Anything else? See, there are multiple information. First, hemoglobin is relatively maintained. There is no blood loss,
Yes,
right?
yes,
KLC
nutrition.
is normal. KLC is normal, right? In the
Yes,
context, patient is
no cooling.
not having any fever. It means it is suggesting that there is no underlying cholangitis. Got my point?
Yes,
Then urea creatinine
yes,
is maintained. Means renal functions are maintained. Then
yes.
you LFT is correlating with the clinical finding of obstructive jaundice, and then albumin is well maintained. INR is well
Albumin is
maintained,
maintained.
right? So
Yes.
liver function is well preserved, P is well maintained, and then CA 19.9. What is the relevance?
CA99 does not have any diagnostic implications, sir. It
But
in
but
some groups,
no, but
CA99
in the context of
has been
ultrasound
deciding.
report, in the context of ultrasound report, can you make out regarding the disease bulk or history or prognosis?
Yes, sir. CA99, if it is highly elevated,
Highly means
some groups consider. more than 100 for an indication for some groups consider it as indication for PET-CT or staging laparoscopy,
Right.
or even sign of metastasis if it is more than 500 to 1000,
Right.
then go for
So
PET-CT.
that way, CA 19.9 is not significantly raised. So you can make out many
Yes,
things based on just blood investigation,
yes, not an extensive disease.
right? And she is a well-preserved patient.
Yes, sir.
You don't expect metastasis
Yes, sir.
based on just CA 19.9, and it is a not a very biologically aggressive disease as far
Aggressive.
as
Yes.
investigations we got till now. Got my point. Then next,
Yes, sir. Next, we went ahead with CT scan triple phase of the abdomen, sir.
uh
I'll just show.
Rajiv, stop share and share again. We are not able to see the CT scan.
Hello.
I think he lost connection. I think, sir, he lost connection, sir. He has to join again, sir. I will call him.
Yes. Sir, connected, sir. Just can I be, sir, host bana? Hello, sir.
Hello.
Sir, am I audible, sir? Am I audible, sir? Hello.
Yes.
Yes, I'll just share my screen, sir.
Hello. Hello.
Yes, sir. Just waiting to become the host, sir, to share my screen.
Hello.
Rajiv, most probably you are co-host now. See?
Uh, yes, sir. Sir, screen is visible, sir?
Not yet.
Yes, it is.
Yes.
Oh,
Yes, sir.
good.
This is the triple phase city of the patient, sir. This is the plane series showing cuts from the lower thorax and the abdomen, sir. In the plane
Yeah.
video, we can see no evidence of effusion, sir. No evidence of any lesion in the lower lung fields. Yes, sir. In the abdomen, liver appears normal in shape and surface is smooth, sir, and margins are sharp. In plain cut, there are evidence of dilated bilateral intrahepatic biliary radicals, sir. No evidence of any free fluid. Pancreas appears to be normal in shape and size. There is no calcification in pancreas, no calcifications in any major vessels, sir. Bowel appears normal, sir. No significant dilatation of stomach and no significant dilatation of any intestinal loops, sir. And next, I'll go to this
What
is
other findings can
total
be useful? What other findings can be useful? You have mentioned calcification. Where calcification? Which part
pancreas,
of
sir.
the anywhere else? Given her age and the
Major vessels are in aorta,
including right aorta where
sir, abdominal aorta, and descending thoracic aorta.
right. So which part of those vessels, major vessels, are important in terms of your surgical planning?
Sir,
That might have some
around
implication.
sir, uh,
It is the calcification near the celiac axis or SMA, right?
yes, sir.
That might be more relevant. Otherwise, the calcification in other areas that might be uh, due to age-related things, right? And
Yes,
that might be
yes,
having some general implications. But for us, I think it is more relevant when it is there in the area of celiac axis and the SMA,
yes, sir. Celiac acid.
right?
So I'll
Next.
show the portal venous phase, sir. Again,
Mm-hmm.
same findings in the lungs, sir. No any lesion, no effusion. In the liver, we can see dilated intrahepatic biliary radicals, bilateral and central. And as we follow, spleen appears normal, sir. Otherwise, as we follow, CBD is dilated. And in this cut, we can also see the dilated MPD in this region, sir. Both CBD and MPD are dilated. And as we go down, both MPD and CBD are still dilated, sir. Portal vein is formed and passing. And here at the region of the pancreatic head, we can see MPD. In this last cut, MPD is seen. After this, MPD is getting obstructed, sir. And just little below, even CBD is getting obstructed by a heterogeneously enhancing lesion in the head of the pancreas, sir, with the hypoechoic center. And the lesion appears to be abutting medial wall of the duodenum, and it is completely compressing the CBD and MPD cell. uh, in terms of poor one second, answers. In the portal vein region, fat planes are maintained at here, sir, at the splenic vein and SMV junction. And when we go below, near SMV in the anteriorly, sir, at this cut, we can see there is a loss of fat plane with superior mesenteric vein and what appears to be a early maybe tumor thrombi inside the lumen, sir, in the SMV.
Yes. I think there is a one filling defect along the lateral wall, right? Like you have
Yes,
mentioned.
yes,
I'm not sure. I'm not
yes.
able to see whether this is extending down below in the SMV, even beyond jejunal
So no,
vein.
sir, it's just
Some
there.
dot was seen, but I am
Uh,
not sure because
yes, yes, sir.
one was
On these
in the
cuts, it
lumen
is
itself.
visible only there, sir, and below and yes, in the lumen, and it is
Okay.
not
And
there below or above, sir. Then arterial phase, sir.
mhm.
Hepatic arteries are normal, sir. Right hepatic artery is passing behind the CBD, and common hepatic artery proper is formed normally, and it is far from the lesion, and
See, if you mention about the
superior
hepatic
mesenteric
artery,
artery.
see,
Yes,
if you
superior
mention about
mesenteric
the
artery. Yes,
if you
sir.
mention about the arteries, then also mention regarding the abnormal
Mm.
course or whether it is accessory or aberrant in terms of hepatic artery, right?
Okay, sir. Yes.
So for most important being the right hepatic artery, if it is a normal origin, then it's okay. If it is it is accessory or aberrant
Abnormal.
arising from the SMA, then that you have to specifically look for it, right?
Yes, there is
And
no. There is,
yeah,
yes.
its course and whether it is involved by head of pancreas mass or not. And second, you have to mention on the celiac axis part also, whether it is a patent or there is a celiac axis stenosis or it is a compression kind of median arcuate segment, like that thing, because
Yes.
that has implication on your surgical planning. Got my point? So once you
Yes, sir.
mention about the artery, then mention all relevant findings.
Okay, sir. Course is normal, sir. No, it is not involved by the pancreatic and master hepatic artery, common hepatic artery, or celiac axis. All of them are patent, sir.
Right.
Then coming to superior mesenteric artery, it is
What about GDA? What about SMA? Common hepatic artery?
is I'll just show and as well as explain, sir. So common hepatic artery is free, sir, and GDA is superior border cell, and S is the left border of the lesion, but fat line and supplementary artery. In this, these are the CT findings.
It is hanging up, I think.
Rajesh, share again. Yeah. Yeah.
Hello, sir. So there's some network issue, sir. Is it visible,
Yeah,
sir?
some network issue is there.
Yes. A large irregular marginated heterogeneously enhancing lesion with areas of fibrosis is seen in the head of the pancreas, sir, measuring through for 3.8 into 4.8 with speculated margin and significant fat surroundings. So am I audible?
Yeah, you're audible.
Yes. There is abrupt narrowing of the distal most CBD with associated significant 2.1 centimeter. And bilateral IHBRD is also there. So male pancreatic duct is also dilated 5.5 millimeter with positive double duct sign. Laterally, the region is, as I had explained, abutting D2 segment of the duodenum, sir, with loss of fat glands. However, there is no significant luminal narrowing, no gastric outlet obstruction, sir. There was no evidence of any in that in clinical examination also, sir, and signs and symptoms. And anterior the lesion is closely abutting superior mesenteric vein at 6 o'clock to 9 o'clock position. They have measured it around 45-degree angle of involvement, sir, with loss of fat planes and tumor thrombus, sir. Uh, Early tumoral thrombus in the mesenteric vein, and the contour of the vein is also changed because of that. However, there is no significant narrowing of the lumen, and fat planes with the SMA are well maintained. Posteriorly, lesion is abutting inferior vena cava. However, fat planes were maintained, sir. No evidence of luminal narrowing. And a few peripancreatic lymph nodes are enlarged, sir, up to 8 mm. Possibly regional lymph node metastasis, and liver appears to be normal in attenuation. No focal arterial enhancing or hypoechoic lesion is seen in the liver, sir. Port
Okay.
and portal
So
vein
what is your
size.
overall interpretation of this lesion in terms of your staging or resectability?
Sir, since it is a pancreatic head mass with the contour change in the SMV, even though if it is less than 180-degree of involvement, SMV with contour change and early tumor thrombi, it comes under borderline resectable pancreatic head carcinomas.
So what is your plan? How will
Sir,
you
our
approach this
plan,
patient for management?
sir, the involvement of the segment is around 1 centimeter, less than 1 centimeter, sir. We have our plan will be for since the vessel is free above and below, it can be resected and reconstructed, sir.
What about neoadjuvant therapy?
So neoadjuvant therapy have also been found to have better results, sir. But upfront
In this
surgery can
patient,
also be considered if
in this
vessel
patient,
veins are reconstructed. Yes.
in this patient, what will you prefer? Neoadjuvant followed by restaging and then surgery, or upfront surgery?
Sir, neoadjuvant, according to recent studies, neoadjuvant has a better result. So we'll consider for neoadjuvant chemotherapy followed by.
And then you are planning for
Re-
vascular reconstruction, right? You have to resect
Yes,
the SMV. It is not the portal vein.
SMV.
It is the superior
No,
mesenteric
not
vein,
portal veins. SMV.
right? It is the SMV. So when you plan to resect and reconstruct SMV, what are the important anatomical points that you have to consider?
So length of the segment involved, and if the
What will be the limiting factor in reconstruction of the SMV, not about the portal vein? Because in this patient, it is the
distance.
SMV which is seems to be involved, which is involved actually, right? Not the portal
Yes, sir.
vein.
Yes, sir. So distance of the lesion from the SMV and splenic vein junction.
What would be the more relevant thing? It is the towards liver, towards spleen, or towards the small intestine,
Towards small intestine.
right? Why?
So it can compromise the drainage of the small vessels, leading to
Right. So it is
fistula.
the distal anatomy in terms of jejunal veins,
Yes,
right?
suggestional vein.
Yes.
Yes.
So I think it is always better to read these images in coronal as well as in reconstruction to have a better assessment of the anatomy of all the vessels. Because we have a habit of seeing these CT scan only in the axial films. But I suggest that
Mhm.
if you read these films in coronal and then with the vascular reconstruction, that will give you a better idea about the surgical planning, right?
Yes.
it might seem feasible to resect the vein, but it is more important that how you will reconstruct it, even with the some graft, because you have to see distally where the regional veins, what is the distribution, right? Where the branches, and
Yes.
how whether you will be able to reconstruct those or not. Got my point. Had it been
Yes.
in the portal vein, it might be have been much more easier, even with the such kind of presentation. But if it is distally, even
Yes.
primarily in the superior mesenteric vein, they have to then you have to plan well in advance, very carefully, right, regarding the reconstruction. And I think even with the
Yes.
locally advanced disease, borderline resectable, even we are planning to do the reconstruction, I think it is better to reconsider neoadjuvant therapy, right? But in this patient, CA 19.9 is not that high. Suppose it is more than 100. What is the ABC staging or biological staging? Have you heard of? Hello, can you hear me? I think we have lost some connection.
Most probably, sir. No, sir. I can see him, but lost some connection. I think now they have to join again. मैं शेयर कर रहा हूँ आपको. Vishal sir, just wait for 1 minute, sir. Just they are joining again. They have joined.
Sir,
Okay.
yes, sir.
Yes. Yes.
Yes, network issues, yes, sir.
Yes,
Sir,
sir.
yes, Rajesh. Yes. Hello, am I audible, sir?
Yeah, you are audible. So, what is the
Yes.
ABC staging regarding this C head of pancreas?
It's the borderline, yes, sir. ABC staging is a consideration of anatomical, behavioral, and conditional assessment, sir.
Biology,
Anatomical, according to,
anatomy, biology, and the
sorry,
condition of
biology,
the patient.
uh,
Right. So, if you
biology
see
and conditional. Yes,
in this
condition of the,
patient, anatomy wise, what is that? What is the status?
sir, according, yes, it is borderline resectable anatomical wise, sir. BRA. Since
Okay. And then
SMV, even though it is
biology,
less than 180 degree, but there is a change in biologically, sir, it is CA99 is less than 500, and there is no evident
biologically,
lymph node or lymph node, sir. So conditionally, she is ECOG plus 1, sir. So better than, if not more than ECOG 2. Hello, sir. Hello, sir.
hello. I think we can
हाँ sir.
close
Hello, sir.
this session, I think. Right. Thank you. Thank
Sir,
you.
the
Any other
important
question
thing,
or query, you can just post in GST, है ना?
sir. Vishal sir. Vishal sir.
Hello.
Hello, Vishal sir. I'm audible. It's Anand.
Well, I'm not sure whether I'm audible.